Vamos a proseguir en este simposio con el uso del balón farmacoactivo. Como otros años se ha dedicado una charla, una mesa, ¿no?, al uso del balón farmacoactivo en la enfermedad periférica. En los primeros años habló del balón en el uso arterial y ya hemos tenido alguna presentación sobre el uso en venoso, ¿no?, en fístulas. Entonces agradecemos al doctor Fernando Alfonso que nos invite a participar en esta mesa, y la doctora Moreno va a hacer una pequeña presentación de los ponentes y finalmente haremos un debate acerca de las cuestiones que surjan.
Bueno, en primer lugar agradecer, al igual que mi comoderador, al doctor Alfonso su amable invitación, y simplemente de radiaros lo que todos ya tenéis en el programa. Tenemos unos invitados absolutamente de lujo que nos van a ilustrar sus experiencias. Ahora mismo el primero que va a comenzar la sesión nos va a hablar en toda su experiencia, porque además está iniciando un trial muy interesante sobre la acción de los balones con droga en accesos vasculares. Va a seguir otro, bueno, ya muy bien conocido, sobre todo por vosotros, por los cardiólogos, el doctor Cortese, que nos va a poner al día no solamente la opinión de los expertos, sino también con las últimas aclaraciones que las guías nos recomiendan al respecto de este ámbito. Y por último tendremos la participación, que como también muy bien conocéis, es el doctor Granada, con el que vamos a contactar. Simplemente estamos aquí para ayudar en esta misión de la tarde, el doctor Mingo y yo, y sin más pasamos a las presentaciones correspondientes.
Okay, well, thank you very much for this. I think it's a kind introduction. I didn't understand, but I hope it's a kind introduction. Can you please? Yeah, thank you very much. Okay, I would like to thank Fernando, of course, for inviting me to this nice symposium. It's my pleasure and my honor to be here. And I think it's very well organized, highlighting all the basics and all the state of the art at the moment. So now we take a break from the coronary circulation, go to another field, not even arteries. In fact, we're speaking about veins or prosthetic grafts. Start with some potential conflicts of interest. So I'm an interventional radiologist, speaking for a group of cardiologists, of course. I have a consultancy agreement with the Cardionovum company in Germany that manufactures and markets the Alberto dialysis balloon. And I'm also the PI of a study investigating the use of a drug-coated balloon in dialysis shunts. And this is a clinical trial number. So we're looking at a huge clinical problem, big numbers. What is the clinical problem? So it's the patients who are on dialysis. They have to wait for their kidney and they have to bridge this time. This will grow. This problem will grow because there will be more and more people, diabetic persons who need kidney replacement. So it's something that will grow in the future, number-wise. So it's an arteriovenous fistula for hemodialysis access to bridge the time to the kidney transplantation, and the aim, of course, is to buy time to keep the access open until the patient receives the kidney transplant, which may be never, of course. So the goal of all our intervention is to increase the lifetime span of the dialysis access. And if we have wasted one, then we can go on to another type of shunt, then we can go to the other arm, and at one moment we don't have any access anymore. And at that time it stops, and in fact the patients die. So what is the problem here? So the problem is that if you have an AV fistula, you expose the vein to really, really unphysiologically extreme conditions. High flow, more than 1 liter per minute, and arterial pressure, and which for a vein, of course, is highly unphysiological. And this will cause extreme intimal hyperplasia. It will be very tough, fibrous intimal hyperplasia in the draining veins. The problem is, if we do a PTA, the patency is poor, and we do many repeat procedures. So here's some examples. So here we see a Brescia Semino fistula with a radial artery, hypertrophic radial artery, and an ectatic cephalic vein, and there you see the tight stenosis. Or here in a fistula coming from the elbow, here you see the PTFE graft, and there a stenosis at the venous anastomosis. Always these stenosis occur on the venous side and mostly at the anastomosis. Here another example, Semino, multiple lesions, multiple tight stenosis, in this case to the cephalic vein. Here's the problem in practice. So we see, in this case, an upper arm fistula, stenosis. We do a PTA, and what happens? 11 months later, at exactly the same spot, we see a repeat stenosis, also some ectasia. We know that if we will treat this stenosis now, in 8 months this patient will come back, we'll treat again, in 6 months the patient will come back, etc., etc. So many repeat procedures, and the time interval between those repeat procedures will become smaller. Let's have a look at the numbers. In fact, if you look in literature, there's not so much data out there, but this is what has been published. So, autogenous veins, look at the patency at 1 year, less than 50%. If you look at prosthetic grafts, even worse. Very bad primary patency at 1 year. And then look at the histology. So in this case, we have a PTFE graft. You see a tight stenosis. Here, the specimen, and you see this whitish fibrotic stenosis, which is made up almost purely of intimal hyperplasia. Intimal hyperplasia. So here comes the drug-eluting techniques. So this is the basic premise of the drug-eluting techniques, drug-coated balloons. So for patients with hemodialysis, we want to maintain their AV access. We hope that if we can use the drug-coated balloon instead of a standard PTA, the lesions will show less intimal hyperplasia. So therefore the shunt will function a bit longer. It will increase the lifetime of this specific shunt. It will increase the time of all the lifetime shunts, and therefore increase the patient's life expectancy. At the end of the day, you also hope, of course, that it will improve the cost effectiveness. And again, against this demographic background of growing number of patients who actually need this hemodialysis shunts. So this is the idea. First, of course, look in the animal experiment. So this is a study that our group did then at the University of Rotterdam already, 12 years ago. So this was in a pig. You see the carotid artery and the jugular vein. So we asked this vascular surgeon to make a AV fistula there, PTFE graft, you see it. And at the venous anastomosis, we inserted a stent, a self-expandable stent. It was then the Cordis Smart platform. And we had two types. We had a bare stent and we had a sirolimus-coated stent. We waited for 4 weeks, and I want you to concentrate on the bottom row. So there you see the proximal vein, right near the stent. So on the right here you see the bare stent, and even in this 4 weeks you see quite a bit of intimal hyperplasia. But look at the drug-eluting stent. No intimal hyperplasia at all. So if you do it, the quantitative math, in our case, sirolimus eluting stents, you see a diameter reduction of about 6. Other groups have done similar experiments, not with stents, but with paclitaxel immersed PTFE grafts, or using a paclitaxel mesh around the graft, and they found similar results. reduction of the diameter stenosis by a factor of about 6. So here you have it, the proof of principle. We see that the familiar drugs, sirolimus, paclitaxel, they work, they actually inhibit the venous intimal hyperplasia in a dialysis access. And of course, these are all experimental animals, it's not patient, but it's a proof of principle. So what do we now know about the early clinical experience? Several small series have been published. I think this is the best series of the small series, published in 2015, and they made use of the impact stent of Medtronic or Invatec, in fact. So there's 40 arteriovenous fistulae and graft stenosis. Outcome, the primary patency at 1 year, and again, a huge difference, again by this factor of 6. Conclusion, in this small series, the drug-eluting balloon will delay the intimal hyperplasia. Now we move on in time, and we come now to the Aperto study and the Aperto balloon, which is manufactured in this case by Cardionovum. So this is a paclitaxel technology. Sorry. So here you see a listing of the several manufacturers, and one of the things that really is striking is that there's a huge difference in the particle size. The manufacturer Cardionovum claims that this is a big advantage. I think this has to remain proven, has to be proven in studies, but it's something that catches the eye. This is the clinical data, the best clinical data that has been achieved with the Cardionovum balloon. In this case, it was a registry of 150 patients in several Italian centers. And if we look at the baseline characteristics, well, we see more or less these are the baseline characteristics of the patients that we also see. If you look at the type of stents, we see that in Italy, apparently there's more prosthetic grafts than native grafts. In the Netherlands, this is the other way around. But anyway, it's roughly similar populations. But now look at their data. So this is the primary patency after 1 year. It's 81% primary patency, which when I first saw this data, I fell off my chair because it's extremely good, very good. Look again at these primary patency rates of the POBA balloon. So if this holds true in a randomized clinical trial, then we really have achieved something. So now I'll introduce, let's say, the study of which I am a PI, which is the Aperto randomized clinical trial. So this is a study that runs in the Netherlands and in some university centers in Belgium. It's an investigator-driven multi-center trial, research grant by Cardionovum. Again, in hemodialysis access, and we look at the drug-coated balloon versus the PTA. We use the Aperto paclitaxel drug-coated balloon, which is, by the way, it's the only dedicated balloon for dialysis fistula. We use independent clinical research offices and independent statistical analysis. We want to have 150 patients. We have now more than 90 enrolled. So I hope if you invite me next year, then I can hopefully give you the results. The primary outcome in our study is not so much the angiographic appearance, but the clinical usefulness of the technique. So what we are looking at, in fact, is how long it will take before the fistula stops being adequate for dialysis. So we really look at the clinical endpoint. These are the participating centers, so 2 university hospitals in Belgium and a bunch of hospitals in the Netherlands, including my own hospital in Gouda. So, chairman, chairwoman, I would like to summarize. So if we think about the place of drug-coated balloons in AV access, we have to realize it is still early days. We have a plausible theoretical framework why DEB should do the trick, especially here because it is all pure intimal hyperplasia. We have a proof of principle in several experimental animal studies. We have some small RCT randomized clinical trials with very encouraging results. We have a larger registry also with extremely good results, primary patency 81%, and we are halfway a larger randomized clinical trial. I'm also aware that a similar trial is also underway in China with something like 300 patients, which looks at roughly similar outcomes as we do. I think one thing we shouldn't forget, even if we will have a positive outcome of our clinical trial, other questions will remain. We all know from discussions in the coronary circulation and also in the peripheral arteries that one DEB balloon is not like the other. They have different characteristics. So it's difficult to generalize the outcomes to all drug-eluting balloon. They are too different. We don't know anything about the optimum dosage for the veins, and we don't know anything about the long-term complications. What happens to, for example, the pulmonary vasculatures? And we haven't even touched the issues of life expectancy or quality of life. Okay, thank you very much.
Thank you. ¿Alguna pregunta en la sala? ¿Alguna pregunta?
Thank you. I have one question. Thank you, because it's 150 patients, and it's a very good study. What type of stenosis did you treat? In grafts?
So the study is open for both prosthetic grafts and native fistulas. In, let's say, the Netherlands and also in Belgium, you see that the majority of majority of shunts is native fistulas. It used to be different. I think 15 years ago, we tended to have more PTFE grafts, but now, I guess, like in Spain, we go more towards primary native fistulas.
Do you have a difference between the results of one or type or other type of fistulas?
Well, it's too early to say because we haven't done the analysis. I don't know. What we do know from, let's say, the experience in the plain balloon, as I showed you, is that the prosthetic grafts fare worse. They do worse. I think that's also the clinical experience here in your hands.
Thank you very much.
Dr. Pattynama, do you consider that parameters like TLR or loss of lumen that we use usually in other locations in AV fistulas, do you think that we need only the parameters of malfunction from nephrologists, or do you use, or must we use this another, like in FEMPOP or below the knee?
It's, let's say, that's a very good question. It is a difficult issue, because how do you define the percentage of diameter stenosis in a vein? Because the veins, some get very ectatic and some not at all. For example, and grafts, of course, do not dilate at all. So it may well be that, what seems like a very tight stenosis in a very ectatic vein is in fact not so stenotic. So that's a bit difficult. So I think what is important is what is the clinical implication of this? So therefore, you have this wonderful standardized DOCAI criteria, which says, okay, when is a fistula adequately functioning? Well, it's adequately functioning if you get good dialysis without too much recirculation, etc., etc. Once you have problems like this, well, in fact, then the nephrologist will come to you or to the interventionist and say, listen, we have a problem with this patient, with this dialysis. Then you do an angiogram and you'll see the stenosis. Well, that is the culprit lesion. So what I want to say is that all the parameters that we are used to use in all our scientific work in peripheral arteries or in the coronary circulation may not apply directly to dialysis shunts. And this is the reason that I think it's more worthwhile to look at the clinical effect. Long answer, I'm sorry.
Thank you. ¿Alguna otra pregunta? Bueno, muchísimas gracias, doctor Pattynama, por su interesante aportación. A continuación, el doctor Cortese nos va a ilustrar acerca de esas especificaciones en las guías con respecto al balón con droga y la opinión de los expertos. Muchas gracias.
Thank you, Rosa, for the kind presentation. As I said 2 years ago, that picture was took here in Madrid something like 10 years ago, so I was a younger physician. Yes, my task now is to give you an update, a very particular point of view, my personal point of view, on the latest ESC and vascular surgeon guidelines that have been published recently in the European Heart Journal, as compared to our position paper on drug-coated balloons in the lower extremities. Okay. Yeah. Well, this is something that we all know, but I wanted to just to remind you that a class 2A of indication means that it should be considered, and a class 2B it may be considered because usefulness and efficacy is less well established by evidence and opinion. So let's see and go deeply into the ESC document and see which is the role of drug-coated balloons for this document. For aortoiliac occlusive lesions, it is well stated and clearly stated that an endovascular first strategy may be considered only in case of experienced team, and a primary stent implantation has a class 2A indication, but there's no room for drug-coated balloons. That is something not strange because there are very few data in these specific settings. It is more strange, in my opinion, the position of these guidelines regarding a FEMPOP area, because here, drug-eluting balloon may be considered in short lesions with a class 2B indication. Class 2B should be considered, but it's not the role, and we don't suggest to use it. Another thing that seems odd to me is that they consider small lesions up to 25 centimeters. This is not a small lesion, in my opinion. 25 centimeters for an SFA is a long lesion. And the other point is that drug-eluting balloons, even here, may be considered for in-stent restenosis after failure of a previously PTA with a stent. If we go and analyze the literature, we can see that there are several drug-coated balloons for the SFA, 9 of them that are marketed currently in Europe, and the vast majority of them beat the comparator that is POBA, with a very good, in some cases, very good late lumen loss and angiographic outcome. And going deeper with the 3 balloons that have the more reliable scientific appearance, we can see that they are the Impact, Lutonics, and Stellarix. They all went through very well-designed studies with independent adjudication of the events, and with the primary endpoint that is probably one of the most reliable endpoint, that is a 12-month patency, primary patency at the culprit vessel. Patient population is different across these 4 studies. Diabetic patients are well represented between 37 and 45 and 49%. In some cases, we have a lot of CTOs, like in the impact SFA, 1/4 of the patients had CTOs, and calcific lesions are not an exclusion criteria. And overall, the primary patency at 12 months was good with all of these devices. It was significantly improved if compared to POBA in the SFA setting, with 82 to 89%. That is a good outcome. Quite the same for the TLR. TLR was significantly reduced by these devices, especially for the impact and the Stellar X1 that had around 5% TLR rates at 1 year. One of the main issues with drug-coated balloons for peripheral is the calcium. This analysis clearly shows how a huge amount of calcification, especially if the calcium is circumferential, the outcome is not good. So in this case, you should consider a stent or a bypass or endotherectomy, other treatment options, because drug-coated balloons do not fare well. That's the main limitation of these devices. We also have real-world data, like the IMPACT global study. This is a study that enrolled 1,500 patients. Any clinical indication for these SFA patients, any lesion length. And overall, we have a pretty good lesion length that is longer than the one of the randomized clinical trial. We have also calcifications and large and severe calcifications with good primary outcome and good immediate success of the procedure. And what is interesting is that here the results after 2 years quite well mimic the main results of the randomized clinical trial. But here, as I said, it is a real-world population and a more complex population. So even in real-world patients in this large registry, the outcome is good. And we also have the results at 2 years of the Illuminate-EU RCT trial that have been published, has been presented recently and have not yet been published. And here the results are quite the same, showing that the primary patency after 24 months and the TLR rates are significantly reduced with a drug-coated balloon strategy in the SFA patients. We go deeper, we go to below the knee lesions. Here, drug-coated balloons are not nominated. I think that they should have been nominated, even if we have to say something that is not good, but we should consider this therapeutic option. Here, bypass is considered the first-line treatment for these patients, and the vascular treatment can be considered and may be suggested in some patients with a class of indication 2A. But what seems odd to me is that only one randomized clinical trial has been considered for this part of the guidelines, that is the BASIL trial. It was a trial that started enrollment in the 90s and was published in Lancet in 2005. It was surgery against POBA. It was done mainly by vascular surgeons, and there was no differences in terms of hard endpoint like amputation-free survival, and no difference in terms of quality of life, but higher cost with the surgery. So that's the only one study that is cited by these guidelines regarding BTK patients. I will come back about drug-coated balloons and their potential role in BTK later, but please let me introduce our position paper that was published 1 year or 2 years ago in the European Heart Journal. Its aims were to provide a comprehensive framework to guide clinical practice and to discuss challenges and future perspectives in territories where a gold standard treatment is currently not available and current treatments are of limited efficacy. That was the goal, and we started with limited efficacy that was represented by stents. Overall, stents for the SFA share a very similar rate of TLR after 1 year, that is around 30%, so it's quite high TLR rate, and this TLR is, in case of total occlusion, difficult to be treated. We can also have, in case of longer lesions, an increased risk in stent fracture. And moreover, after 1 year, the TLR rate tends to increase in standard patients. That is something that we have not found in DCB patients between 1 and 2 years. That is the longest follow-up that is currently available. We also give some technical consideration and suggestion for the FEMPOP PTA. First of all, balloon insertion and navigation should be done very smoothly, very easily in order not to lose the drug. Predilatation is mandatory, even here. You should cover the entire lesion with the EDCB from healthy to healthy using long balloons. And you have to avoid the geographical mismatch. That means that if you have to stent a lesion after drug-coated balloon, you don't have to exceed with a stent in the entire area of the drug-coated balloon treated segment. You should only do a sort of focal spot stenting. And what about BTK? Well, the first data about drug-coated balloons for BTK were pretty good. This is a proof of concept study from Schmidt. They used the impact balloon, impact amphibian, that was at that time available in the cath lab. Complete wound healing at 1 year was very good, 74%. This is a very complex population, as you well know. And restenosis was rare and typically focal. So, from the concept point of view, it was a very interesting treatment strategy. We also have one randomized clinical trial, the first randomized clinical trial. We have 3 of them actually, in CLI patients with diabetes. Here patients were randomized to amphibian dip, drug-coated balloon, and standard PTA, and the results clearly show how 12-month restenosis and the rate of occlusion and TLR were significantly reduced with drug-coated balloon. The problem arrived later with the same balloon. This is a larger randomized clinical trial, a similar patient setting, CLI with a high percentage of diabetes, multi-center study. The study failed in obtaining an improvement in late lumen loss, and that is something strange and not expected, but it also failed in obtaining the non-inferiority regarding the safety endpoint. This item was mainly driven by an increase that was slightly significant, not at all significant, but there was an increase in the amputation in drug-coated balloon treated patients. So this study was a failure and brought to the retrieval of this device from the market. There are many possible explanations of this failure after the first preliminary good data. I don't have the time to go through it, but I have to say that there was a lack of a surveillance program. There were not, in all the centers, there were not dedicated diabetic foot clinic that are something that are very important when you treat this type of patient. These are not patients that you may want to dilate with any device that you want, but you have to take care of from the beginning to the end and during the following months. And that is something that was missing in many centers of that study and not in the first 2 centers that did the first 2 studies. So some technical consideration even here. This is a really diffuse disease, so if you use more than one drug-coated balloon, you should also consider that the drug uptake may be a little bit high. Balloon insertion and navigation may be complex even if you predilate the lesion, so you may have some drug loss. You always have to predilate to avoid geographical mismatch, and you have also to consider that for very distal lesions, the success is low. And finally, that is the most important message. If you want in selected patient to use drug-coated balloons for BTK, you should consider that it is a multidisciplinary team, more than any other setting where the cardiologist is accustomed to treat his patients. So this is my first slide. This was not obviously a confrontation between the guidelines and the position paper. They are 2 totally different documents, so there is not a winner, but there are some important differences that I want to remark. First of all, the first one, the ESC, is an omnicomprehensive document with major societies' endorsement. And the second document is a document that was written by experts in DCB, both in the coronary and in the peripheral tree. In the first document, DCB experts were not arrived, and the final point is that maybe I have to say something, at least in the choice of the scientific analysis that has been made in the ESC guidelines. Thank you.
Thank you, Dr. Cortese, for your extremely interesting examination of the theme. ¿Alguna pregunta en la sala? Nos acaban de informar que estamos ya con posibilidad de conectarnos con el doctor Juan Granada y por si acaso alguna cosa no es muy fuera de tiempo, pues vamos a proseguir, si os parece bien, con el resto de la
So I have a question regarding stents, because you showed the slide of in fact it was the 2014 analysis of stents done by Bianino, and you said, okay, not so wonderful patency and also stent fractures, but of course this was the first generations of stent. So how would you now, let's say with the next generations of stent, look at Supera, look at the drug eluting stents, how would you rate stents now at this moment?
That's a good point. Okay, that's a good point. Even here, the technology has changed a lot. I have to say that in our cath lab, we married the DCB philosophy since the beginning. So we started. No, we didn't stop, obviously, but we reduced the stent implantation rate by 50 to 60% in those years, in 2013, 2014. So we have very limited experience with the newer devices. We also have drug eluting stents for the SFA that may fare well. But I think, I do believe that for the SFA, not for other areas, but for the SFA, at least the first treatment should be at least attempted with the drug-coated balloon, because you don't leave nothing behind. And in case of restenosis, it is easier to retreat the lesion, unless you have very calcific lesions. But that's just a personal point of view.
I think that is the problem. There's a real lack of real data comparing the several types of treatments. I think that is a problem, and that is something that should be addressed.
Yeah, one of the limitations of this analysis is that, as you said, there is no direct comparison between BEAR or DES and the drug-coated balloon. So we may have more data. I don't know actually if there are any trials running on the topic. But it could be interesting.
The problem is we are changing all the time. We have many devices, and we don't have simultaneously something to compare really by pairs, for example. And now we are moving with new technologies, and we can compare the old one 5 or 6 years ago.
But I want just to stress this point. I didn't want to say that we should use only drug-coated balloon in our SFA patients, but we now are around 20% of the whole SFA treated with drug-coated balloon in Europe, and that's a good number. And we have 30% in Germany, where they have dedicated reimbursement. So what I expected was that the guidelines, the European Society of Guidelines, could be more liberal in suggesting this treatment option.